Hello, good afternoon. I hope you have a very good lunch. My name is Midnight. I am the Executive Director of APCOM. Welcome to the APCOM Shivananda Symposium. Just to make some sort of housekeeping announcements, please can you ensure your mobile phone is on silent? And of course, if there are any questions that you want to pose to the panels, please write them in on your mobile phone. Welcome, June. We're just waiting for you, please. Thank you so much, APACC, for inviting us to be part of this session and also to honor the founder of APCOM, Shivananda, who some of you may know as such a leader within the movement and such a visionary. He really ensured that the issues around HIV, particularly for gay men, MSM, and transgender people, is also part of the National Strategic Plan. So in 2006, there was this big conference in New Delhi that brought together civil society organizations, activists, UN agencies, and then also donors and governments to discuss about how best do we move forward on to ensuring that the rights of LGBTQI people and also HIV services will be provided at country level. So as part of the 10th anniversary of honoring his legacy, we're so honored also to be part of this session and having the Shivananda Symposium here today. I'd like to introduce our esteemed panelists that you can see with us here. We have Heather Marie Schmidt, who is from UNAIDS Regional Office for Asia and the Pacific in Thailand, working and also working on the global HIV hepatitis and STI program for the World Health Organization as well. Welcome, Heather Marie. And we have Dr. Won Chen Song, who is from the National Center for the Infectious Diseases, Tan Tuk Seng Hospital in Singapore. We also have Cronus Kwok, who is the Assistant Director of the MSM Outreach Program of Action for AIDS in Singapore. We have June Chua, Executive Director of the T Project. And last but not least, Alaric Tan, founder of the Greenhouse Community Services in Singapore as well. So this session, we'd like to have an update onto what is the HIV situation in the region. And then Dr. Won Chen Song will talk about the exciting project and findings that we have in 6 territories in this region, and also specific findings from Singapore. And then Cronus will have brief discussions with June and Alaric in terms of the missing populations and data here in Singapore. So without further ado, I'd like to introduce Heather Marie Schmidt to give us an update on what's happening in terms of the HIV epidemic in the Asia-Pacific region.
Thank you, Midnight. And can you hear me okay? Yeah, cool, great. So thank you, Midnight, and it's a pleasure to provide an overview of the HIV epidemic in Asia and the Pacific. So the most recent data we have is to December 2021. Where are we in the region? There were 6 million people living with HIV. This is about 16% of the global number of people who are living with HIV. There were, unfortunately, 260,000 people who were newly infected, about 17% of the global burden. There were 140,000 AIDS-related deaths, and this represents 22% of the global number of people who died related to AIDS. So quite clearly, we are not on track to meet global HIV elimination targets. Within our region, between 2011 and 2021, there has been a decline of about 21% in new HIV infections overall. But that masks the substantial difference between countries. And as you can see here, some countries have experienced reasonable declines, while others have experienced crucial increases, including the Philippines at over 300% increase in new HIV infections. When we look at the change in AIDS-related deaths, you can see that regionally, there has been a decrease of 54% since 2011. This is amazing. But again, this regional average masks the enormous disparities and inequalities within our region, with countries like Pakistan experiencing an over 500% increase in AIDS-related deaths. Looking at these AIDS-related deaths, this means that people are not diagnosed soon enough or are not on treatment. Either way, without current treatment options, this should not be happening. And it's no surprise to anybody here that our epidemic within Asia and the Pacific is concentrated among key populations and their partners, who accounted for 96% of all new HIV infections. However, key populations remain criminalized in most countries within our region, with some level of criminalization. So, for example, with sex work, same-sex relations, or criminalizing aspects of living with HIV. This contributes towards stigma and discrimination, contributes towards HIV vulnerability, and to poorer access to information, to poorer access to prevention, testing, and treatment, and compounds the issues that we're seeing. The situation among young people is even more dire. So young people account for about a quarter of new HIV infections within our region. In some countries, including Myanmar, Thailand, Indonesia, the Philippines, Cambodia, and Laos, this is a much larger proportion. In addition, the number of new infections, or the proportion of new infections, is growing in some of these countries. And they're accounting, for example, in the Philippines, are largely driving that increase in the HIV epidemic. And key populations remain underserved by HIV services. Testing coverage is suboptimal. About 50% of female sex workers, men who have sex with men, trans women, and trans people, and people who inject drugs, on average within our region, having testing coverage. When we look at HIV prevention, the situation, again, is not better. And prevention coverage is similarly very low among these populations. And this contributes further to the inequalities and becomes a vicious cycle. Looking at pre-exposure prophylaxis, and this data is to 2022 because I have access to earlier data, you can see that while there is a huge need to scale up innovations across our region and to better deliver prevention services, PrEP uptake in 2022 is completely insufficient to what we need. So PrEP access within our region is patchy. And uptake is not proportional to either the numbers of people who are living within a country, to HIV need, or to any of these gaps. So incidence, prevalence, or HIV need. The target for PrEP within our region is 4 million people on PrEP by 2025. We are currently at about 140,000 people, so 3.5% of that target. There is a lot of work that we need to do, and this is just for PrEP. And finally, looking across the HIV care cascade. So within our region, 76% of people living with HIV know their status. Now, this shouldn't be surprising when we looked at the HIV testing coverage, right? At about 50% of key populations having testing coverage. Perhaps it's a bit higher than you might have expected. So 76%, far below what we want, which is at least 95% of people who know their status. Because unless you know your status, you cannot access HIV treatment and you cannot be virally suppressed. The proportion of people living with HIV who are on treatment is 66%. And so this, again, should be unsurprising given what we know about AIDS-related deaths within our region, that those are really, not decreasing fast enough. And among those people who are living with HIV and who are on treatment, 60% have a suppressed viral load. And of course, viral load suppression is incredibly important when we look at the concept of U equals U, undetectable equals untransmissible. If we want to end the epidemic, we want to prevent onward transmission, treatment is incredibly important. So it's important not only to preserve life and to preserve health, it's important for HIV prevention as well. The situation within our region doesn't vary very much depending on the gender. So women have a slightly better cascade than men, but overall, these are still not very encouraging numbers. And so while we do have countries within the region that have achieved 90-90-90, and now with UNAIDS, we're aiming for 95-95-95, too many countries have not achieved one and particularly all of those minimum standards in terms of coverage. So there is a long way to go until we have that kind of coverage within the region, so 95-95-95. And so I know that this is kind of a sobering view of the epidemic. There have been amazing pieces of work, there have been amazing progresses that we have had in terms of service delivery, differentiated services. The rollout of PrEP is still a success story. We just have a long way to go. And amazing, work with trans women across the region. Really, there is a lot of good work, but what we need to do right now is to amplify that and to make it not the exception, not a best practice, but the standard practice, the standard of care. And so it's clear that we need to overcome a level of complacency, a level of business as usual. HIV has and was deprioritized in a lot of countries. COVID happened, life happens, thing happens. And so there was, I think, overall in our region, a little bit of a reduced focus on HIV. And so we need to accelerate the response, but we need to do more than accelerate the response. We need to do things differently. We need to not accept the status quo, and we need to make sure that we are taking the innovations, they're not innovations anymore, they should be standard of care. And that we need to make sure that we're doing that and that that's prioritized across the region. We have an opportunity. We have the tools. We have the knowledge. Now we need the will. And so a big thank you to my team at the UNAIDS Data Hub who prepared the slides, and a big thank you as well to all of the people involved in the HIV response across the region, the activists, the advocates, the clinicians, the researchers, the partners, and just everybody who supports it, because without all of us working together and the communities, we won't get anywhere.
Thank you so much. Thanks so much, Heather Marie Schmidt. That was overwhelming in terms of the numbers of people who are supposed to be on PrEP, 4 million, but we're not even at like, 3% only?
3.5%.
Gosh, yes. Yeah, we need to do so much better. Maybe Chen Song might have some answers. So Chen Song will be talking about this HIV Care Continuum and Beyond project and findings from 6 territories, and also presenting some findings from Singapore as well.
Thank you so much, Midnight. And thank you, Heather Marianne. So what the speaker who came before me has shown is that some data arising from the region, telling us how we are doing, a report card essentially of the progress that we have made and the the distance that we still have in front of us. So the question is, what do we have to do, and what can we do, what should we do about it? And I think that was the question at the heart of the what I'm going to be spending the next 10 minutes talking to you about, which is the HIV Care Continuum and Beyond project, the results of which are published in a white paper booklet that you can find at the back of the room. So I do urge you later on to just pick up a copy and read through it. And I'll be bringing you through what the work that's been done, the incredibly hard work that's been done over the last 2 years, most of it virtually. I was just talking to Midnight that it's so surreal that all of the work that we have done on Zoom virtually across different time zones is now actually in a physical copy of a booklet that we can look through. I think we have established that the Asia-Pacific HIV landscape, it remains an urgent global public health issue and definitely a regional one as well. I think some of the data has already been presented. What we realize is that the distance that we have to cover in order to really end AIDS in our region, and therefore as a subset of the global AIDS response, is really quite considerable. The initiative that was undertaken was to set up a steering committee of experts from 6 Asian territories, comprising clinicians, public health experts, advocates, community organizations, and people who are living with HIV and patient advocates. This was established in 2021, funded by VIV Healthcare, and in partnership with a number of organizations that you can see there, including APCOM, IHRI, Treat Asia, AMFA, the Taiwan Law Association, Love One, and so on. The steering committee members really came from all the 6 territories that I talked about, and these were, and they're sort of on the screen that you can see there, colleagues and friends who really came together to discuss key issues that we thought were important in order for us to have a consolidated and consistent response towards HIV in our region. Now, the objectives of the project were ambitious, and we recognize that, but across the participating Asian territories, we wanted to ignite discussion and start a process of sharing knowledge, sharing what we knew and had experienced across our territories in terms of HIV care, prevention across the cascade. We wanted to ensure that HIV became a priority again for public health programs, for ministries, for civil service organizations. We wanted to reinforce the premise or the principle that the continuum of care had to be centered around people. People who are living with HIV, people who are at risk of HIV, people who are caring for people living with HIV. At the end of the day, we wanted to be able to deliver very real, practicable, and actionable solutions. And where solutions were not immediately obvious, we wanted to have insights into how these solutions could come about. And all of these were to feed into a goal that we had, lofty goal of helping to bring about an end to HIV/AIDS. So this is a bit of a busy slide, but essentially the work that was done was twofold. Part of it was highly academic. It was generating research findings and data to help us inform the recommendations that we were going to make. This included an extensive multilingual literature review through the published literature, and through this literature review, we generated 4 key challenge areas: prevention, testing, diagnosis, and treatment of HIV, HIV-related stigma and discrimination, and number 4 was quality of life for people living with HIV. We then wanted to leverage and find out whether there were any real-world case studies, especially across the 6 Asian territories that comprised this project, to see whether best practices could be gleaned to inform our white paper. The second arm of it, arguably more importantly, was a very rigorous process of community engagement. In September 2022, there were 33 HIV experts as well as community participants who came together and held virtual discussion sessions to really talk about the issues that were raised through our literature review. And key takeaways were generated, which included, I think, primarily need for a greater focus on U equals to U as the basis of effective prevention, and the need to use more innovative, more modern use of social and traditional media across all territories to engage young people and other key populations. Now, I come from Singapore, I practice in Singapore, and I live here. I'm going to just share very quickly some key findings that were generated from both the literature review as well as the community level engagement regarding Singapore. So generally, Singapore has a low prevalence of HIV, less than 0.2% of the population. New cases in 2021 was about 250 new cases of HIV. In terms of our cascade, 91% are on treatment, more than 94% are virally suppressed, but only about 80% are aware of their HIV status. So we have a way to go in terms of our first breakpoint. When you talk to sort of HIV care practitioners in the country, almost all of us will tell you that the main barrier that we have in terms of prevention, in terms of getting people tested and linked to care, is still HIV-related stigma and discrimination, which I think is not new across our region. People have reported fear of discrimination, of being judged by their healthcare professionals, something that we are working on very rigorously to try to address. Being subjected to what is perceived as state surveillance, perhaps, because of the need for notification to the National Registry. HIV-related criminalization is still, as it is with many countries in the region, still a problem. And of course, issues with regards to workplace discrimination and the lack of proper anti-discrimination laws. Both the Ministry of Health and the Health Promotion Board use sort of messages around, sort of more conventional messages around prevention, such as abstinence, the use of condoms, and monogamy as the foundation or the linchpin of HIV prevention messages, although there is an increasing focus on the use of pre-exposure prophylaxis. But as you can see, community engagement efforts did sort of bring up the fact that there were still important barriers to PrEP uptake in Singapore, including cost, confidentiality, and of course, stigma around PrEP use, which once again, not unique to the Singaporean situation, common across all of the Asia-Pacific territories. Rapid testing and anonymous testing is widely available in Singapore, but despite this, 62% of new diagnoses in Singapore in 2021 presented with a late stage of diagnosis, and barriers to testing still remain. And you can see there that stigma, both internalized as well as anticipated and experienced, are still key to the testing barriers. So quality of life for people living with HIV who are aging with HIV remains an issue as well. And oftentimes, people living with HIV feel that as they age, they become more and more overlooked, more and more invisible, because much of the sort of the attention towards HIV prevention especially, but also long-term care for people living with HIV has not focused on the needs which are unique and may be changing as experienced by people who are older. So, having talked a little bit about the Singapore sort of experience, what do you find in the white paper? So we have launched the HIV Care Continuum. There are 14 core recommendations that are in it, which are tailored for various stakeholders and various partners. So some of them are tailored to policymakers and government. Some of them are tailored towards healthcare professionals. Some are tailored towards community leaders, because we recognize that the response for HIV is multi-sectorial and multidimensional, and the recommendations need to be tailored therein. There are 8 real-world case studies across the 6 Asian territories, which we hope will illustrate sort of best practices, which we hope will illustrate inspiring examples of how certain barriers were overcome and good results were obtained, with a detailed analysis of key issues and a call to action. These are the overview of the recommendations, and you can see that they're divided into testing, diagnosis, and treatment, stigma and discrimination, quality of life, and cross-cutting recommendations across all of them, with, of course, prevention at the start of it as well. I am going to not go through the entire list of case studies, but what I want to highlight to you when you go through the paper is that how the recommendations are structured is that we will have the recommendations with a specific case study, in this case, for example, that of Taiwan, about how you can advocate for U equals to U to challenge HIV-related stigma and discrimination as an illustration of the recommendations that we have. So our sincere hope, I think, on behalf of all the other members of the steering committee, is that when you look through this, you will see that a rigorous process of really thinking about the problems that affect our region, that affect the territories that we live in and that we practice in, was undertaken, that we came up with solutions and insights that we hope will help you in your very specific challenges that you face, and that the white paper will be a useful tool for you to use at the end of the day. So I am at the end of my time. I am going to screen through this and say that together we can end HIV and AIDS in Asia, and my sincere thanks to the partners and endorsers of the care continuum and beyond. Thank you.
Thank you so much, Chen Song, for that really comprehensive, but really brief but comprehensive presentation. And and as Chen Song said, the white paper is available right at the back of the room, and APCOM is so honored to also be a partner in this. And we actually launched this at the World AIDS Day just last year, and it's good to see it now in physical form. So the next session, I'd like to hand over to my co-chair, Kronos Kwok of Action for AIDS, to talk with June and Alaric with the Singaporean civil society groups.
Thank you, Midnight. As you can see, I'm not Sumita. My name is Kronos. Sumita unfortunately had some family emergency to attend to, so I'll be replacing her as a co-chair for this session. I'm from the Action for AIDS Singapore. I oversee the MSM outreach program. And I'll maybe just hand over to my panelists to maybe do a self-introduction first.
Okay, so I'm Jun Chua. So I'm always introduce myself out and proud transgender woman living in Singapore. I don't know whether I'm a tokenism person here or not. So I manage a shelter for the homeless transgender community in Singapore since 2014. And since day one, my shelter admits persons living with HIV. And then in 2019, because I want to be more inclusive, right? So in 2019, my shelter also admit LGBT person living with HIV. So since day one, since day one till today, there are always person living with HIV living at my shelter, staying at my shelter. And also I want to add, I think all this I do is without any funding, out of my own passion.
Hi. Yeah, so my name is Alaric. I'm the founder of the Greenhouse. We are a drug use recovery center for marginalized and vulnerable communities. 90% of our clients are actually gay men, and half of them are already HIV positive. Because sexualized drug use, chemsex usually carries very high risk for HIV infection and transmission. So I myself am a gay man, and I was using drugs for almost 20 years before I managed to stop using. And I set up a Greenhouse mainly because I feel like drug use within these target populations is not very well understood. Our clients actually present with at least one traumatic experience with an average of 5. They present with up to 15 traumatic experiences. So we have a trauma-informed approach because we realize that the substance use is not going to stop unless we find out what the underlying issues behind use are. Surprisingly, most of the time it's rejection from the family because of gender identity, sexual orientation. Yeah, so I feel that there's a lot of work that's ahead for us, but it's amazing that we are beginning to have these conversations about it, changing the way that we look at supporting the people who use substances.
Okay, thank you. I think one of the key issues that we have been discussing throughout this entire conference, and even the session just before lunch, was this idea of HIV stigma and discrimination. One of the speakers earlier, Dr. Ho, mentioned that when she first started doing HIV work 30 years ago, she was already talking about stigma and discrimination. And until today, we are still talking about stigma and discrimination. So it almost seems as if this is something that we can't eradicate, despite the efforts and the attention that we give to it. I think one of the perspectives that I have with my social work training is that, you know, it's a systems issue, right? We do not exist in isolation. We interact with family, friends, we interact with co-workers, we interact with fellow students, and then on the wider aspect, we interact with media, we interact with legislation, we interact with social norms. So all these things actually contribute to stigma in one way or another. So while we advocate, we are able to advocate within our spheres of influence. Sometimes the wider realm can be quite difficult. And especially now, if we talk about stigma and intersectionality with transgender persons and persons who use drugs, that adds on another layer of complexity to tackling stigma and discrimination. So maybe can I get June and Alaric to talk a little bit about how the intersectionality actually impacts your work in eradicating stigma.
Yeah, so I recognize that. So recently, a client at our center newly diagnosed with HIV, and he made an appointment to see me. We sat down and chatted about it. And of course, this person is young and well educated, a lot of access to resources. And I had to remind him that no matter how good the science is nowadays, the moment that we have this diagnosis, certain thoughts will appear in our head that I've made a mistake. This is something that it's so bad that I can never repair it because it can't be cured, right? Even though we can treat it. So even though intellectually we know that it's not going to affect us in many ways because we'll live a normal life, but the stigma, the discrimination is self-inflicted. So this thought that I'm dirty now, that I've made a mistake that I cannot correct is going to be there. And I had to remind him that no matter how smart and clever we are, no matter how well we understand the science, that the first year of the diagnosis is a difficult time. Don't do anything sudden, take your time, be gentle and patient yourself. These are things that we need to remember to do. So at the greenhouse, I mean, it's helpful because we have a community of people. Half of us are HIV positive, so we talk very openly about it. But this is a very different experience from people who are not at our center. I feel like, we have this biopsychosocial approach looking at the body, the mind, the social networks. And the science is great. We can look after the body, and we have a lot of counseling now. It's beginning to be more trauma-informed. But the social connection piece is always missing. And I feel that's something that is really important for us to look at and provide in order to overcome stigma. So when we hang out with other people who are HIV positive, living with it for a long time, and we see how well they're doing, there are a lot of things we don't need to explain or say. We understand immediately by observing them that we can get better as well and we're going to be fine. But I think it's very hard to change stigma and discrimination in the community, but the internalized stigma is something we can work on by providing this kind of social support networks for them.
Okay, I want to say a disclaimer first. So I'm a former sex worker of 20 years. So I don't have research background, I don't have the PhD. So when we talk about stigma, I don't know. So I only got my own personal experience with my community. So when you talk about stigma surrounding people living HIV, but then we are the transgender community already stigma because we are transgender already. So another layer of stigma we can handle one. We embrace stigma one. Also, this is like, so we are used to the stigma. For the transgender community, you'll be surprised in Singapore, there's still no trans-specific HIV program in Singapore for the last 10 years. So when you talk about stigma, right, we are talking about my community wanting to go testing, wanting to know more about PrEP, but they don't have access to any available information because all the information out there is very MSM. But then the transgender community, we got different needs and wants, like gay trans men. So gay trans men having sex with another cisgender or trans men. But then the gay trans men will have a functional vagina. So when they attend, when the gay program include the trans men, but the messaging, the information is still kept the same. So when the gay trans men want to go there, they will perhaps worry about pregnancy. They may get impregnated by their partner, but then that information will never appear in HIV prevention or whatever information for the gay men. It's always condom use, condom use. A few years ago, I heard about condom fatigue, right? Is it still going on? And then we are always a participant. Going back to the white paper, the transgender community we always participate, focus group discussion, everything. The white paper, we are always a participant. We are always invited to the table. Then when we participate already, we are swept off the table. So when the program roll out, we are always excluded. This is, I don't know, this is from my experience. We are always excluded. I had to reiterate again, there is no trans-specific, trans-focused HIV program in Singapore. So I really look up to the Tangerine Clinic So when we talk about stigma, haven't reached us yet. We still want to talk about access to trans-focused HIV prevention, workshop, programs, information. I've been talking about this for the last 10 years. I remember one conference when people, when the MSM program asking for 1 million to improve their program to outreach to more people, and then the heterosexual were asking for like how many hundred of thousands to improve their program. Then I was asking, then when it's my turn, I was just asking for 5,000 to print some leaflets. Also don't have, I'm still waiting. Okay, my time is up. But I have a very good relationship with everyone. The project is about building bridges. But then if I don't say this, I'm not doing my job. Thank you. Thank you.
Thanks, June, for highlighting all these issues. I think one of the interesting things that both Alaric and June brought up is really the idea of having HIV seems like you have done something wrong. It's bad, and you are like to quote Alaric, you are dirty. I think this really can be traced back to how we conduct our sex education. I guess in Singapore, I'm not sure if elsewhere. We always use a very sex negative approach, right? Abstinence, be faithful. So much so that if you do contract HIV, you have done something wrong because you did not follow the abstinence approach or you were not faithful. So there's a lot of shame and a lot of guilt and self-blaming that becomes internalized in a person living with HIV. So perhaps one of the first steps really is to look upstream and correct this thinking and try and have a more sex positive approach towards our sex education, because after all, sex is meant to be enjoyed, it's meant to be pleasurable, and it's what makes us human. And so if we can really think about reframing our idea on what sex is, that there could perhaps be some improvement in addressing HIV-related stigma. I'm not sure if Chen Xiong would like to say anything, because I saw him previously, right?
I think, as I shared in the what was actually uncovered during the process of both the literature review as well as the community engagement, there are I think there is a widely held perception that the conventional methods of prevention messaging or education leave a lot to be desired. But I think what is a optimistic advancement, I think, is that across the territories, including in Singapore, there is a growing recognition that PrEP is going to be key in terms of HIV prevention, right? Where it is not sex negative, obviously it's used in order to facilitate a safer way of having sex without, greatly diminishing the risk of HIV transmission. Also messaging around U equals to U, which essentially, normalizes sex for people regardless of HIV status, right? It becomes a status neutral, to borrow something that I've learned from Dr. Nitaya about, status neutral, HIV neutral sort of testing, prevention kind of messaging. So I think there is change, but as Heather said, the main problem is how quickly it's occurring, and that the fact that we know these things work, we know we should be doing them. Why aren't we doing them fast enough? So I think maybe that's a real key thing that we have to address. Yeah.
Sure. I mean, I just really wanted to agree with the importance of prevention messaging and normalizing sex. I mean, we all do it or want to do it, or, but there is a pervasive, particularly in Asia and the Pacific, there is a pervasive shame and stigma associated with sex. And that stigma that's associated with sex really underlies the stigma that's associated with HIV. It's the stigma that's associated with LGBTI individuals, with key populations, with sex work. And I'm going to say, you know, it's the root of our problems, pun intended. And so really normalizing that, helping to, and through using very empowering, gain-framed messaging. Let's not focus on risk as the way to get people into prevention, the way to get people in testing. Let's look at how can we help you have a better sex life? How can we help you overcome any fears that you have, reduce inhibitions, and just basically be happier? And so I think if we can use the power of PrEP, the power of U equals U, to champion that kind of messaging, that's only going to be a good thing and hopefully will help us accelerate our progress towards, you know, towards 2030.
Yeah, I just wanted to chime in about the sex positive thing because I think it's really important. Almost all of our clients are presenting with guilt and shame over their sexual orientation. So they are having sexualized drug use, they are not using condoms. So 100% of them are at risk of catching and transmitting HIV. So when we have our counseling internship program, when these volunteer counselors come to our center, we train them in the SSTC model, sexuality, substance use, trauma, and co-occurring disorders. But the sex positive thing is very interesting because we have conservative women, religious, and it's really mind-blowing for them to understand this is the way you need to approach it. You never shame the client. So we ask them like, are you having sex? And when the client says yes, we're like, yeah, you're having sex. It's really important because it makes them feel safe to talk to you about the kind of risk factors that the kind of risky behavior you're engaging in. So I think training is also an important part of this because we talk about being sex positive, but what does it mean, especially in a clinical setting? Oh yeah, so because of this approach, like every single one of our clients who come in, we are able to ask them about their risk exposure for HIV and STIs, and we will refer to Action for AIDS for anonymous testing. So almost everyone who comes through our doors will have a test or already know their status and get on treatment. And those who are negative and still engaging in risky behaviors would be put on PrEP.
Yeah. So one of the things that I do as part of my job is I provide sexual health counseling to gay men that come for anonymous HIV test. And one of the incidents that I remember was a client actually thanked me for introducing him to PrEP because he said that with PrEP, his sex life actually improved. As in, he enjoyed sex a lot more. Before PrEP, whenever he had sex, he will always be quite paranoid. Like, would the condom break? Would his partner take out the condom without him knowing? And so on. So he's always very paranoid. And every time he has a sexual encounter, he would come to the clinic for a test because the paranoia just drives him crazy. So after he started on PrEP, you know, obviously he is less worried. And when you obviously worry less when having sex, you do enjoy the sex a lot better. I think we have some time for questions from the floor. If anyone would like to ask any questions.
There's a question.
Hi, I'm Rahim from Pakistan, and thank you Midnight for acknowledging Shivananda Khan. I remember back in 2010 when the services were started, the community-based services were started in Pakistan. So he was an Indian, but I'm very proudly saying that he's my guru, and he laid the HIV community-based services in Pakistan. And thank you, Heather, for the very nice presentation. So talking about Pakistan, you said it's 504%. So the situation in Pakistan and in India and in Nepal are like similar to each other. But in Pakistan, I can only talk about Pakistan. So the situation for transgender community and MSM community is totally different there. When we go out in the field and we go out to the grassroots level people, they are more engaged, and there is a Khwaja Sarak community. So the dynamics are totally different from here. So they are raped, brutally raped. So when we conduct the studies, like 15 to 20 times penetration in one dance party, in a one function, and unprotected sex, and increasing the rate of chemsex and all that is one of the major factors. So one of the studies we recently conducted on chemsex, most of the issues are related to mental health, and unfortunately UN is no doubt working there. So the lack of mental health support, and of course the acceptance of government that we are doing their work which they cannot do, the state cannot do the work the community is doing. We are like penalized, we are going through that. So these are one of the major factors that are the causes of increased rate in HIV prevalence in Pakistan.
Thank you. I think that that was a lot of really interesting and useful information to provide context. One thing I wanted to maybe flag, it's a little bit shameless promotion, is with UNAIDS and UNAIDS, we have developed a chemsex provider toolkit, which we will be disseminating soon. And the focus of that really is, there are toolkits and a lot of resources for community-based organizations, but I think one of the gaps has historically been providers being able to respond sensitively to issues of chemsex without necessarily looking at it as something that they really need to preach abstinence for, which is not going to work with everybody, and certainly is usually a very confronting place to present the exploration of chemsex, and how do we really help you get through, how do we help you in that sense. So that will be coming disseminated soon, which hopefully will be useful in countries that will need to be adapted through into the local context, because it is a regional toolkit.
My apologies if I'm taking so much time. So yes, the toolkit will be a very helpful thing. Still, the dynamics are totally different. So is there any possibility if you can give trainings to the people who are service providers? And because there is no professional available. I am also doing with there are organizations working on IDUs. So I recently went to the north part of the country. I'm one of the biggest organizations working in Pakistan. So I asked them, if someone comes to me and to our organization, or to any organization in Pakistan, if they need help, they need support, as within 6 months of starting ICE, you're finished. I've seen those cases. Like, I've seen the people dying in front of us. We cannot do anything, and I just need that if this panel can provide support to the people, even in Pakistan, India, or anywhere. So
I think this is something that we can discuss offline about how the toolkit can be, so dissemination in Pakistan.
Hi, thank you so much. First of all, I want to thank June for your honest feedback. I think it's very important. My name is Hua. I'm a transgender woman from Bangkok, Thailand. So I learned from this morning that being a transgender person, you are most affected by HIV infection, and it's 68 times most likely that you are going to get infected by HIV. And I couldn't think of anything but patriarchy society. But I have one particular question to ask all of you on the stage, that how can Singapore do more and scale up for trans-specific HIV program in Singapore? I think that the question I want to ask the state, and maybe those who have money and who have resources in this room can help answer, because 68 times is really very critical here, and because and also I think 20 years ago, my colleague Kantini Sarama from Malaysia, she is a transgender woman, and she yells a lot. And what she do is that she told everyone that she made that we are not MSM. Transgender is not MSM. So I want to take that from 20 years ago that, you know, the leading trans activists doing a lot before we can have a transgender specific program this day, and taking that spirit and asking the state, how can we scale up transgender specific program in Singapore?
So, I'm sorry, I'll just go first because so we are talking about the greenhouse having this biopsychosocial approach. We are adding a fourth dimension, spiritual, as in clinical definition, meaning and purpose, putting good use of our lived experiences in helping others. So we are about to hire a transgender woman as a team member, like the third staff member at our center, because we find that the lived experience piece is very important. So as a gay man who overcame trauma and addiction, so we want her to do the same thing. So when we talk about scaling up, I feel like she's a trained peer supporter. So she went through addiction, trauma, rejection from family, that sort of thing. So I feel like we really need to think about who we want to engage. Those people who live experience have very powerful advocates, but then we also need the funding to make sure that they have employment so they can do the work. So we're not really intimidated by the amount of work that's ahead. We're quite excited at the possibilities of working with the community to make sure that we can maximize impact.
I heard you say your friend shouting for 20 years. I only 10 years, so I feel better now. I think this question is best answered by them. But then again, elaborate friend, but doesn't mean hire a transgender person will have transgender specific programs. So you must say, I hire a transgender person to manage my trans focused program. Not only hire, but from my experience, when any organization hire a transgender person, right, but they still ask the transgender person to manage gay-centric programs or manage programs that is not transgender related. Just like me here lah. I'm like a token. Okay, move on. Okay, sorry.
No, I think where we are at the moment is we are trying to do more collaborations with community partners. So AFA, for example, we do partner with T Project to conduct testing for the trans community. Yes, although it's at the moment where we are now, it's not ideal. There's no trans lab program, but there's trans engagement in that sense. So we're not at where the ideal state is, but we're trying to make steps towards that. So we're looking forward to more collaborations with June, hopefully.
I don't want. You all got the funding for the collaboration, but I don't have the funding leh. I do it because my community asked me. That collaboration that Kronos talking about is because I collaborate with AFA because my community have been asking for it. That's why I did it. So if the next collaboration you want to collaborate, I need funding already. I'm not going to do it just for you all to collect KPIs. But again, I and Kronos friends, we are friends. I volunteer for AFA.
Thank you, June.
Go ahead.
Yeah. So Midnight, would you like to?
Well, I'm so sorry. I know that you can talk a lot more about this issue, but we're closing because there's going to be another session after this. But I'd like to say, I think in terms of the findings that Chen Song talked about in the white paper, that's looking at like 6 territories that are countries, territories that are transitioning out of funding availability from Global Fund, from PEPFAR. So they're relying on other sources. So I think the issues around like funding for community groups, as demonstrated here in Singapore, you can see there are issues around like where communities can get sustainability to do intersectional issues and have a trans-specific programs, as June mentioned. Some other, like it's not saying like other territories can also do much better, but it also depends on the funding, particularly for their community-led organizations and service delivery models. the white paper also talked about the innovations that communities are also doing, particularly around the service delivery, differentiated service delivery models during COVID-19, and being able to take an active role in terms of service delivery to the most vulnerable populations. But these are certainly not funded for by certain projects and programs. Eric talked about intersectionality between drug use, for example. Like, those are things that are not being programmed at country level at the moment. So I think what we're saying in terms of the communities, we want to ensure that how to ensure that funding goes directly to the community organizations, how they can also lead their own responses and be able to respond directly to the community groups that they are engaging with, right, that they're already gaining trust with. And the UNAIDS also have that as a target, 30, 60, 80, ensuring that these programs and project service delivery models actually go to the community organizations. So I hope that next time we have these conversations about service delivery, we are actually talking about how much is it within those service delivery models are led and for the communities at the territories, led by the key populations themselves and for the key populations themselves. So I'm so sorry we have no more time for other questions. I want to say thank you so much for your availability, for joining this Shivananda Khan session. There is an online form that please do send your comments in so we can ensure that the next NGO Symposium will be much better. And also that in this same room, Summit 2, there is a session on opportunistic infections, and the rooms next opposite will be an abstract-driven session. Thank you so much for joining the Shivananda Khan Symposium. Thank you so much for our panelists.